Thank you. Jaime Hernandez. I represent the Advanced Heart Failure program, and on behalf of our surgical side, via Dr. Reddy, I'm going to talk about non-cardiac interventions in patients with recurring high-profile transvalvular pumps. So we're going to try to emphasize the unmet need among high-risk patients with impaired myocardial function requiring non-cardiac surgical interventions, and reviewing a case, trying to open up our programmatic approach to patients with impaired myocardial function requiring these sort of interventions to bridge to the next step. Our vision, we have cardiac shock as a platform of our vision, and of course, as the majority of advanced heart disease recovery and replacement programs, it's an interdisciplinary team that helps decide what is the perhaps best intervention. And as we have multiple temporary MCS options and we try to tailor devices, we need to define an intended transition, and hemocompatibility sometimes will limit other potential interventions in order to make these patients candidates for the next step. And if the next step is not only deciding whether it's replacement or recovery, it's truly deciding towards longitudinal well-being, a lot of these patients will need to be additionally profiled from a non-cardiac standpoint to get to the next step. And yes, we know that transvalvular pumps like Impella 5.5 has the possibility to provide ambulatory, hemodynamic, and then organ stability, and help us with perioperative bleeding, ICU length of stay, and of course reduce the need for replacement of other end organs. From the cardiac perspective, however, what happens when you have a non-cardiac issue, that requires heart support? So we're going to talk about a case. We had a 66-year-old smoker female with multiple comorbidities, including a prior history of coronary disease, that presented with bloody diarrhea and intentional weight loss and a fall. Ended up in the emergency room intubated with refractory shock on multiple vasoactive agents, high white count, high lactate. An echo was done. Now that echoes are pretty much at the expenses of every frontline caregiver, with severe LV dysfunction, with a pattern suggestive of a stress-induced cardiomyopathy pattern, and free air and sigmoid and a sigmoid colon mass, as we can see there in the TEE. So again, in this particular case, decision was made to proceed with surgery beforehand, stabilizing the patient with a transvalvular pump. And again, this is just a granular case description, but again, the patient underwent exploratory laparotomy, sigmoidectomy, small bowel resection. Patient had a lot of other abdominal complications, but across the period of time was supported with Impella 5.5, heparin-free. As you can see, a protracted course within the next 2 or 3 weeks under support. And eventually, a patient had, after her conditions were resolved, signs of LV remission with an echocardiogram showing normal LV function. And again, the patient was able to heal up her abdominal catastrophe initially or regionally and transition to rehab and then home. So this is just an extreme case, of course, but it just sort of highlights what we have done, and we were able to look back at the procedures that we have done under Impella 5.5 as bridge to recovery or versus replacement, such as this one, like exploratory laparotomy, but there's other ones like laparoscopic nephrectomy, cystoscopy, bladder mass resections, lung and liver biopsies, and of course endoscopies with biopsy, and that possibility of doing all these procedures under cardiac support and heparin-free, I think helping patients that originally will not have an option and will be discouraged for transition to whether it's a heart transplant evaluation or a heart or an LV evaluation or just an emergent surgical intervention based on cardiac risk. I think that has been mitigated by that possibility of myocardial support. I think this is just the beginning. We think that there's many more further research required in order to best understand the current procedural patterns, knowledge gaps amongst these vulnerable population, require non-cardiac interventions with myocardial dysfunction. And along with Dr. Brozzi, I think we're shifting towards this concept of interdisciplinary teams that were just focused on the heart towards truly building blocks for innovation. And again, I think along with Nico and others at the Colón Clinic, we're very hopeful about further collaborations. Thank you.
Okay. And just, I think it's a final presentation, and we have a couple of virtuals. Basically, evolving a little bit on this concept. These are the disclosures. Just to have a little bit of a background and to put things in perspective, over 10 million of male non-cardiac surgical procedures are performed every year in the United States. Of course, we know about the increasing prevalence of heart failure, and we also know about the impact of severe left ventricular dysfunction in patients undergoing any surgical procedure, resulting in increased risk of mortality. Needless to say, much increase in those patients in cardiogenic shock. We know how robust is the hemodynamic support that is provided by the transvalvular pumps, particularly the 5 and 5.5 more recently. We did a recent review of our experience with these procedures. And basically it comes down to, this is very initial experience, but 4 patients, you see the age is there, undergoing with long-standing history of cardiomyopathy. One of them ischemic, the other 3 non-ischemic, rather young patients, as you see there. They were all had been started in inotropic for several months. And when they got this readmission to the hospital, they were all in overt shock. 3 of them received intra-aortic balloon pump as an additional measure to try to stabilize them. And eventually all of them required to transition and upgrade mechanical support to Impella CP 5, more recently 5.5. And these are the surgeries that they received. You see a nephrectomy, a cholecystectomy, and 2 sleeve gastrectomies in patients with morbid obesity, as you see BMI of 45 and 52. These are, in a nutshell, the results, and maybe I'll take your attention to the lower half of the table, the BC table, but basically 2 patients require transition of support. 1 patient required to go on ECMO, and the other patient required eventually to go on a Jaime 3 because they were not able to be weaned off the Impella. The other patient, actually the one that went to ECMO, progressed to stage E, cardiogenic shock, after receiving the cholecystectomy, and eventually was supported to transplant. Actually, 3 of the patients were successfully bridged to transplant. This is one of the patients, and just example of the trajectory of the history of his heart failure after long-standing ischemic cardiomyopathy, eventually over 2 decades progressed to advanced heart failure, requiring initiation of milrinone over a course of several months, and then he had this readmission with progression of cardiogenic shock, where he required addition of vasopressin, intra-aortic balloon pump, and that was not enough to stabilize him. I don't know if you can play the videos of the echocardiograms, but basically with an ejection fraction in the 10% range, he required escalation to Impella, trying to stabilize, and during the workup for a potential transplant, this mass was identified as suprarenal tumor that was eventually successfully removed with a retroperitoneal approach by the urologist. This patient was not able to be weaned from Impella after the operation, eventually in the context of the recent tumor resection, and so was bridged to Jaime 3. And eventually later, a year later, he was successfully transplanted and is doing well over a year after the transplant. Some considerations in these cases, definitely we try to do them with cardiac anesthesia. They certainly are the most indicated and better trained to manage different vasoactive agents, being mindful of the volume status. And so patients have invasive monitoring, as you can see there, and also a TE to help optimize the management during the operation. Cardiac surgeons certainly are involved in the implant of the devices, and we remain standby. And we have the ECMO standby in the operating room in case we need to step up therapy, of course. 3 of the cases, by the way, were done with laparoscopic approaches. With the, we need to create the pneumoperitoneum. That decreases the venous return, and so adds additional challenge and potential to compromise the RV, which we didn't see in either of the cases. And this is our most recent case. I'm sorry, the image is flipped, I guess, on the right, but just to show you how stable the patient remained as he came in. What is happening with these obese patients is that they are, with the new allocation system, and so hesitant to go on an LVAD and eventually potentially never be eligible for a transplant. And so we are exploring these new alternatives, and with the Impella, provide adequate hemodynamic support to offer them a sleeve gastrectomy, like in this case. The echocardiogram will show you the severity, 10% EF as well in that case, give or take. And patient got successfully supported through a sleeve gastrectomy, was sent home within a couple of months, had lost 80 pounds, and was eligible for transplant, was successfully transplanted 3 months later. In terms of anticoagulation, and Dr. Hernandez adhered to that, referred to that a little before, we stopped the heparin 4 to 6 hours before the operation. We use a bicarb solution through the purge of the Impella, and that remained through the operation and in the 12 to 24 hours after the operation. If there is no evidence of postoperative bleeding, then we restart anticoagulation, systemic anticoagulation, and change the bicarbonate purge for the regular heparin purge. So our initial experience has been satisfactory. All patients survived the index admission. 3 of them were successfully transplanted. There is a precedent in the LVAD literature, supporting this patient through different kinds of non-cardiac operations. The adoption of the alternative anticoagulation strategies has not affected the performance of the pump, and of course, we need further experience. This is just the beginning. Thank you.
Thank you very much. I think we have 2 of your colleagues, or Dr. Gopalan and Dr. Rosenthal are online.
Good morning. My name is Raul Rosenthal. I'm at the Cleveland Clinic, Department of General Surgery. I'm a bariatric surgeon, and I'd briefly like to go over the benefits of bariatric surgery, rapid and durable weight loss when it comes to cardiac health. We've done a study looking at pericardial fat, how rapid weight loss will impact pericardial fat. And we know that because of its location, the pericardial fat can result in coronary atherosclerosis and coronary pathology. So we did a linear measurement of the fat thickness, 113 patients, sagittal planes, and we were looking at the thickness of the pericardial fat as it's depicted in this picture. We used the Framingham Heart Study and predictors for coronary artery disease at 10 years. And here you can see how we conducted these measurements in the sagittal plane. And this has translated then to a certain number. And we looked at it in patients before and after surgery. So you can see 383 before, 363 after surgery, with a decrease in the width of the pericardial fat. We look at patients with an average age of 55 years, hypertension, diabetes, all the medical conditions you can imagine. And as you can see here, before and after surgery, the pericardial fat was significantly decreased. So a beneficial effect of rapid weight loss and bariatric surgery when it comes to pericardial fat. And that translates also to a decrease in coronary artery disease, as you can see, that was significant as well at 10 years with a relative risk reduction of 17%. We also looked at ventricular conduction, because if you decrease pericardial fat, not only you decrease the risk of atherosclerosis, but you improve, or we assume that you can improve conduction. So we look at epicardial, pericardial fat, looking at the conduction waves. This was done also with electrocardiographic components. And again, you can see here how as pericardial fat decreased after surgery, the QT interval and the QTC interval improved dramatically in this patient population. We looked also at the ejection fraction of the heart, specifically in those with heart failure. This was a retrospective review. We looked at echocardiograms, and we compared patients with heart failure versus patients without heart failure. And we look at left ventricular ejection fraction at 12 months after bariatric surgery, which is when you have the most weight loss. What did we see? Not surprising that the ejection fraction significantly improved after 12 months undergoing bariatric surgery when compared to patients that did not have bariatric surgery. You can see the left ventricular ejection fraction after the procedure significantly improved in patients with heart failure due to rapid weight loss, rapid and durable weight loss. We also look at the heart geometry. You know, when patients start gaining weight and the heart gets heavier and the pericardial fat gets heavier and the chambers get bigger and start failing, the geometry of the heart will change. As the patient loses weight, the heart will come back to its normal position and the chambers also improve. There is a remodeling, a concentric remodeling to normal geometry. We look at atrial mass, and what we found was that the left ventricular mass index and contractility with obesity following rapid weight loss surgery improved. And you can see here how we determine the changes of these parameters. So we looked at ventricular mass, ventricular contractility, and shortening of the ventricles. Before and after surgery, you see a significant and dramatic impact with bariatric surgery with a very strong correlation. This doesn't happen just because. What happens with infiltration of fatty tissue between the atriums? Does this lower the risk of new onset of atrial fibrillation? The answer is yes. We looked at changes in interstitial, interatrial fat and how this changes the incidence of atrial fibrillation in this patient population. We measure it with CT and electrocardiographic parameters. Here you can have a better picture how this gets measured. And what did we see? That the peer interval decreased, got better, and the interatrial fat decreased as well. Both of them significant results with a decrease in the risk of developing atrial fibrillation. Just to conclude, we also look at does rapid and durable weight loss have an impact in hospital admissions in patients that have diastolic heart failure and severe obesity. And we conducted a retrospective analysis of the United States National Inpatient Sample Database that collects 5 million patients. This is the largest database. And what did we see? Surprisingly not, that the hospital admissions for diastolic heart failure was significantly lower in patients that underwent bariatric surgery versus those who did not. And that concludes my presentation. I look forward to have a discussion. Thank you very much.
And do we have other online attendees for the discussion?
Yeah. Hi, Mark. This is Reddy.
Good afternoon.
Good afternoon.
Welcome. Were you
Thank you.
Was there another video that was going to be shown, or no? Just for the discussion. Okay. I think, as I mentioned earlier, this is really intriguing extension of the indications for mechanical circulatory support, and I guess I'll ask a first question. Would be somewhat concerned about taking patients, the one you described with, sepsis, abdominal sepsis, and putting a foreign body in the heart and leaving it there for a little while. Have you had any issues with endocarditis, any issues with wound infections, persistent bacteremia from potentially the device being contaminated? Or
So yeah, we saw on surveillance cultures that everything was persistently negative. Of course, the patients were on prophylactic antibiotics postoperatively due to the fact that it was a perforation with exploratory laparotomy. So again, extreme cases like this are not being done routinely, but we thought that the fact that the recovery potential was a stress-induced pattern, perhaps from the sepsis and intra-abdominal situation, perhaps support will not be longer than a few week or two. So again, we put, in the balance having a 60-year-old lady with a potential recovery cardiomyopathy. And again, I don't know, Ram, what are your thoughts? But we put a lot of all this risk in the balance and a lot of discussion with the family, with the patient, and we thought that the alternative was death. And I think when you have these situations, I think it's a salvage decision-making that requires a lot of shared decisions with the team.
Mark, that's a great question. Actually,
yes, go ahead.
Can you guys hear me?
Yes.
Yeah. So, generally speaking, I think that's a great question. It needs to be done with multidisciplinary agreement. I think, and in this case, we had our ID colleagues, our general surgeons, and obviously the cardiac surgery and heart failure involved. And we made a good choice, I think, in the end. I think the things that have changed this completely, one, I think this is a temporary device, not a permanent device. So, and when we remove the device, I take the entire graft out. So I don't staple the graft, I take everything out. So we've had a good run with patients not developing wound sepsis. The first patient that we did this on, in fact, had an empyema, and I had to go back in that chest 3 times just to clear things out. And the fact that we don't use heparin systemically or in the pump anymore, I think has made a huge difference to us. We do give subcutaneous heparin, but we don't use systemic heparin, and we don't use heparin in the purge solution. I think that's made a huge difference.
When you're confronted with these cases, perhaps, what's your thought process? And maybe you're just going to use an Impella CP, something quick, or versus taking these patients and actually doing a surgical cut down, putting a 5.5 in. How do you make the decision between the two?
Well, we are talking about all patients with decompensated heart failure. Eventually, you saw the transition of devices, and eventually the CP, or the 5 or the 5.5 will provide the most robust support. So I don't think, I would argue one of our patients, a younger patient, a 22-year-old with rather small arteries, we had to use a CP.
In the axillary position?
Well, eventually would not advance. He had some stenosis. We had to use in femoral position. We had to use a CP, and that was enough to support him through the operation. That was the one with a BMI of 52. As you can imagine, we were there and already had access on the other groin in case we had to bail out with ECMO. Of course, it's an extreme example, but proves the concept in a way.
Yeah, now from our standpoint, we're just trying to shoot for robust LV unloading that is ambulatory, that sets the stage for subsequent transitions, whether it's further profiling, rehabilitation, or getting to the next step in their journey, whether it's remission, replacement, recovery, or replacement.
I think a very important issue here, there are two important issues. One, I think we get the patient ambulatory, and you can get them extubated ambulatory, and that makes a huge difference for them. The second thing is, I think that you want to give them the maximum support you can up front, rather than letting them get sicker and then having to escalate. So I think from both those standpoints, the 5.5, I think, is
Yes, I would agree. In general, as a surgeon, when consulted, we usually reach for the most powerful pump, and it would make sense for all the reasons that you've mentioned. I'm really intrigued by the bariatric surgery and the change in the phenotype of these patients from rapid weight loss. Are these patients being essentially recovered, and we have the obese patients in the heart failure clinic that are being turned down for LVAD or transplantation, but are these patients getting bariatric surgery and then being able to be weaned to GDMT and are free from the heart failure clinic?
No. This is initial experience, and so the count is 2. So it's a case series already, not a case report. No, but actually, the work Dr. Rosenthal presented, that's 2 decades of work with bariatric surgery. So needless to say, when we face these patients that were reluctant to get an LVAD, and in the context of the new UNOS allocation score, and so, and we reached out to him, the answer was, when do we do it? Of course, we had that advantage, but developing the concept, the truth is, all the benefits, we are treating the sickest patients. These were all stage C, D, really already quite advanced. We understand when you go by LVADs and those patients that eventually receive an LVAD with the prospect of getting a bariatric surgery down the road, and no, actually only 30% of those eventually receive bariatric surgery and were successfully transplanted. So it's not a great proposition. The other thing that I would want to mention is we did a quick analysis of the NIS database of 7 million hospitalizations in 2018. About 1 million had the BMI reported, and about 3,000 patients had BMI above 35, and they were admitted with cause of end-stage heart failure or cardiogenic shock. So there is we understand there is a large population of patients out there whose care may be neglected, and we may have the opportunity to help them.
How do you open that discussion with your colleagues? Historically, that would be a difficult discussion to have, and I would think most institutions might be somewhat reluctant to go down this path.
Well, we are convinced we can help these patients, and certainly as we do more, we may find challenges and things that we need to correct. We are encouraged with this initial experience. Certainly, as you go along this pathway, the adherence of the patient in terms of subsequent, after the bariatric surgery, these patients need to be adherent as well to the therapies that you implement and with the dietary restrictions. And so will also, in a way, prove their prospective adherence for a transplant, correct?
Any questions from the audience? I think this is very intriguing applications of mechanical support. Have you had any problems with lack of anticoagulation in these patients? We know the pumps are very hemocompatible, but lack or adding anticoagulation back post-surgery and bleeding complications?
No, so far we have had 4 to 6 weeks at the most. We have had to exchange 1, but it was mostly due to malposition, causing some degree of hemolysis. But we have had good results so far with the bicarb approach. We do DVT prophylaxis with sub-Q heparin or sometimes low molecular weight heparin. But overall, we haven't seen pump thrombosis, for example, or device thrombosis from that. I think the post, in terms of bleeding, device removal, et cetera, it has also been very successful not to use heparin in these patients. I don't know, Ram, what do you, yeah.
I have a question. It's impressive that we're able to do this, but it seems like Impella as a bridge to lab chole is expensive. How do you get this reimbursed? Because the DRG wouldn't cover this, right?
Yeah, actually that patient was on Impella, was being supported on Impella, stabilizing from her admission in cardiogenic shock. And her BMI was 27. She was being stabilized for a prospective transplant when she developed acute cholecystitis. So she had to go for her cholecystectomy. Actually, that's the one that during the operation, immediately after the operation, we noticed she was in stage E heart failure, and we had to transition to ECMO. Impella stayed venting the ventricle. We stabilized her, got her through that, and 2 weeks later she got a transplant.
That's a good question, though.
There's a quick question for Dr. Hernandez.
Sure.
Go ahead.
Dr. Hernandez, this is Radha Gopalan from University of Arizona. The question is, most of your experience is in inpatients, or have you had any experience with elective admissions and elective placement for bariatric surgery?
Yeah, I mean, all the patients that we have done have been inpatients and not elective indications. I don't know, Nico, what's
No, the same.
Clinic?
This is a very initial experience. As we prove the concept, you could entertain and think of those patients that will come in a more stable condition, eventually get supported, like the last case we did. The patient went to the operating room, one anesthesia, got the Impella 5.5. As he was stable, we proceeded with the bariatric surgery. Went to the ICU, was weaned off, and within 8-9 days was going home. But he had been admitted. He had been admitted in shock, correct? He was on a balloon and Milrinone before going to the operating room.
I think it'll be important.
I'd like to share with you, I'd like to share our experience. We have done Impella support in outpatients who require elective bariatric surgery who are considered high risk. These are patients with ejection fraction less than 25 who have Canadian angina class 4 with non-revascularizable coronary artery disease, as well as low ejection fraction. For example, we did a 60-year-old gentleman whose BMI was 41, not a candidate for transplant. He required transplant for both indications, heart failure and intractable angina, but he couldn't undergo because of the cutoff BMI. So a decision was made to undergo high-risk bariatric surgery. So he was, after outpatient discussion with the patient, he was admitted 2 days before the proposed surgery, underwent a right heart catheterization with an indwelling Swan-Ganz catheter, and his cardiac index was 1.8. So we placed him on inotropic support for biventricular support, and then elective placement of axillary cut, Impella 5.5 for LV unloading and reduce the ischemia burden. So the patient successfully went through the surgery and was discharged 4 days after, and we gave no anticoagulation for the Impella during the time except the purge with bicarb. Interestingly, there's always a question, are your anticipated risks and complications going to happen intraoperatively or not, and which poses a big question. There's no crystal ball where you can say something will happen. This gentleman, during the surgery, had non-sustained VT and developed hypotension, and was treated only with antiarrhythmics and did not require any other escalation of therapy, simply because of the protected nature of the preparation that was done before the surgery. It's something that we continue to do as an elective procedure. Patients who are outpatients who are brought into the hospital proactively and then placed with Impella to undergo the procedure.
Well, I think it'll be very important to collect this data, and hopefully we can hear some more about it at next year's ACURE as the indications for Impella are being expanded. But I'd like to thank you guys and thank our guests on the panel for this discussion. It's a great way to end the day with some food for thought and intriguing applications of acute cardiac unloading. So thank you all. And I guess you guys don't have to get up. I'm going to finish. I get the opportunity to close, and it's a pleasure and an honor to participate. I'd like to thank the support from Abiomed and congratulate Jerry and Noam and everyone at Abiomed that put this together again. It's fantastic, and certainly thank Dan and Naveen who really are driving this and leaders in the field. Every year new basic science, new exciting clinical data. I think leaves us all energized when we leave here. So I look forward to next year. Thank everyone for coming. Hope you enjoyed the meeting. I certainly did. And I look forward to next year.